Hi, my name is Lorenzo Cristoni. I am a consultant in acute medicine at Frimley Park Hospital. In this presentation, I'm gonna introduce you to the abdominal and renal module of the famous and Kusich curriculum. The examination of the abdomen with the use of ultrasound can be difficult for several reasons. First is the complexity of the structures in the intraperitoneal structures and the retroperitoneal structures. Then the suboptimal conditions where the clinician caring for the acutely unwell patient can operate, particular patient that is not ideally fasting, patient who can have conditions that increase the amount of gas in the abdomen, and we know that the gas is the physical barrier to the penetration of the ultrasound beam. But at the same time, the ultrasound imaging of the patient presenting with a condition that requires our approach is very useful. It can actually change the mind of the patient and always give useful information. According to the famous approach, there are 7 points on the abdominal wall that need to be scanned in order to answer very specific rule-in and rule-out questions. These questions that are clearly displayed in this slide, in the template of the abdominal report of the famous study of the abdomen, are related to the main organs that need to be identified, which are the kidneys, the spleen, the liver, the hemidiaphragm surrounding the liver on one side, the spleen on one side, and then the virtual space of the Morrison, of the spleen recess on the left, and of the Douglas pouch, and then a question related to the presence and degree of hydronephrosis on the left and the right kidney, and ultimately information related to the bladder and whether or not there is fluid around the bladder. And the final question is whether or not there is enough fluid to be tapped. So, what are the main objectives of famous studies? There are mainly 2: identifying fluid in the peritoneal cavity and establishing the amount of fluid, whether or not this fluid can be tapped or drained. And the second question is related to the presence and degree of hydronephrosis in the patient with an acute kidney injury, to identify an obstructive cause, so a surgical cause, against a medical cause of acute kidney injury. So, as clearly stated in the template of the report of the famous study, what are the organs, main organs that need to be identified in a famous study? They are the big parenchymatous organ, the liver and the spleen, which are intraperitoneal, the diaphragm, the spleen and the bladder, and also, of course, the kidney, which are retroperitoneal. What famous does not teach is to identify pathologies related to the biliary tree, the pancreas, the gallbladder, the aorta and inferior vena cava, the appendix and the bowel in general. And also to draw conclusion about the vessels, the major vessels, through Doppler imaging, and also to report about focal lesion of the liver, focal lesion of the spleen, and stools. So in particular, when it comes to identifying the possibility of an obstruction of the urinary tract, we are supposed to report the degree of dilatation of the kidney rather than of the cause of this. That could be, of course, be a stone or a hypertrophy of the prostate. So let's start with the peritoneal fluid. The peritoneal fluid, who is anechoic, so appears as black under ultrasound beams. It allows the complete transmission of the ultrasound beam because there is no impedance reflecting the ultrasound beams. Tends to accumulate in the most declined position inside the peritoneal cavity. What are these spaces? They are virtual space, they are potential space that become evident when actually fluid fills them. We're talking about the Morrison space between the kidney and the liver on the right, the splenorenal recess between the spleen and the left kidney on the left, and the Douglas pouch in women between the rectum and the uterus, and in the rectovesical space in males. So how do we approach the patient where we suspect the presence of intraperitoneal fluid? So we will put the patient supine. We will use the curvilinear probe, the 3.5 MHz probe, in order to explore deep structures. We know that with the curvilinear probe we will have good penetration at the expenses of a poor resolution. And we will position the probe initially in a coronal position on the right upper quadrant to explore structure as the liver, diaphragm, costophrenic angle, and kidney on the right, in order to identify particularly the kidney and the liver, and on the coronal position on the left, in order to identify the space between the spleen and the kidney. So we will have information about two of the main declive position of the peritoneal cavity, which are the Morrison and the splenorenal. And then we will go down to explore the Douglas pouch, first in the transverse position, and then also in the coronal position, right above the symphysis, pubic symphysis. And if we find something, particularly if we find fluid, then we will go into the paracolic gutter to quantify the amount, because there is where the fluid will collect when the amount of ascites is considerable. Because first of all, the fluid will collect in this virtual space, then around the two major structures of the liver on the right and of the spleen on the left, and then among the intestinal loops and along the two paracolic gutter. In these slides, we see how the probe is positioned on the right side of the abdomen, the coronal position that can be even intercostal. Actually, is intercostal. You need to put the probe above the ribs in the coronal position with a dot pointing upwards, so that whatever appears on your screen on the right will be cranial, and whatever appears on the left of the screen is caudal. And with this projection, you will have to identify the diaphragm, the liver, and the right kidney, identifying the Morrison pouch and the fluid that could be collecting in this virtual space. With the left upper quadrant coronal view, we will identify the spleen, we will identify the diaphragm, we'll be able to identify the kidney, and so the virtual space between the kidney and the spleen. But also we will identify easily the costophrenic angle, and so we will be able to also say whether or not pleural fluid is collected in the left costophrenic angle space. Once we have identified the presence of ascites, the following question would be whether or not this fluid can be removed, can be tapped or drained. In this case, we will continue scanning along the flank and in the paracolic gutter to identify the biggest pocket of fluid, and then we will possibly, using the caliper, measure how deep is this pocket of fluid and how deep we would be encountering the first intestinal loop in order to safely insert the needle or the drain. So in this slide, the coronal view on the above the pubic symphysis identify actually the presence of the uterus in the middle, of the bladder on the right, and of fluid which collects between the bladder and the uterus, but also behind the uterus, between the rectum and the uterus. This is an imaging of similar projection, but in the male subject, where the fluid is actually collecting behind the bladder and in front of the rectum. When it comes to imaging the kidneys, we will need the patient supine or with the torso mildly elevated, 45 degrees, and then using the coronal view, approaching the patient on one side and the other side, on the flank, on the right upper quadrant, on the left upper quadrant, using the natural window that are the spleen on the left and the liver on the right, that allows the ultrasound beam to pass and then to image the underlying structure very well. We will be able to image the kidney on the long axis. Once the long axis has been imaged, then we will swipe to image from side to side the entire organ, and then we will turn, rotate the probe so that we can also image the kidney on this short axis, and then tilting or moving the probe up and down, we will be able to have imaging the kidney from the upper pole to the lower pole. And this is necessary to have a full assessment of the kidney and not to miss any degree of hydronephrosis. In this slide, we have just a reminder of the anatomy of the kidney, where we can see vascular structures, we can see the cortex, which appears less echogenic, so darker on ultrasound, and then the sinus with the pelvis, which appears more echogenic, bright, also for the presence of fat around it, and then we will be able to identify both the pyramids and the papillae. Here is as it appears on an anatomic piece and the corresponding ultrasound image. So less echogenic cortex and more echogenic bright pelvis. With regard to the degree of hydronephrosis, The hydronephrosis is no, okay, again, number 18. Okay, so our aim is to diagnose or rule out hydronephrosis. So the question we have is whether or not there is hydronephrosis and what is the degree of hydronephrosis. We know that the hydronephrosis is traditionally divided in 3 degrees. In the first degree, we will have just a dilatation of the renal pelvis, but the calyx will be not dilated. In the second degree, we will have a dilatation of the pelvis and the calyx, so that the appearance is of a communicating calyx with pelvis. And in the third degree is when the dilatation is so pronounced that the cortex is compressed and thin. Here is an example of a kidney that has a mildly dilated pelvis, but not real calyx dilatation. This is another example. In this case, it is clearly a higher degree of hydronephrosis where both the pelvis and the calyx are dilated and they form a unique cavity. In this third example, we have a third degree hydronephrosis. Clearly the dilatation of the pelvis and the calyx is so pronounced that the cortex is compressed, is thin, and is potentially atrophic. In this case, the kidney function is likely to be very compromised. A comprehensive assessment of the urinary tract included an assessment of the bladder. The bladder is an image along 2 orthogonal positions of the probe. One is the transverse, just above the pubic symphysis, and one is the coronal, above the pubic symphysis. The probe need to be then swiped up and down to have a full image of the bladder, especially when the bladder is only partially repleted. You will have to tilt downwards the probe on its transverse position to identify it. Using these 2 projections, we will be able to draw 3 diameters. One is the eighth of the bladder, one is the width, and one is the length. By multiplying these 3 diameters and by 0.52, we will be calculating the volume. We will be estimating the volume of the bladder. This is just to resume what I've already explained. To image the bladder using the curvilinear probe on its transverse position above the symphysis and on the coronal position above the symphysis. The bladder will appear as an anechoic structure because it's filled with fluid, thin-walled. By just applying our visual assessment, we will be able to identify or estimate the volume, but we can also then measure the volume in the way that I already explained. And by identifying the bladder, we will be able then to assess for the presence of fluid in the Morrison pouch or in the rectovesical recess. This is an example of how to dynamically scanning a bladder with a probe positioned above the symphysis and oriented longitudinally, so transversally. The probe needs to be moved up and down and tilt also caudally and cranially to fully appreciate the organ. So in this clip, the probe is positioned in the same way, so transversely, and the bladder is identified, but also by swiping fluid between the bladder and the rectum. The free fluid between the rectum and the bladder is identified. In this clip, we can identify the bladder on the right, the anechoic structure in the middle actually, and free fluid on the left. Please notice that the differential diagnosis of what is bladder and what is free fluid is helped by the presence of intestinal loops floating in the acidic fluid. In conclusion, the aims of a focused abdominal study is to, on one side, identifying the presence of free intra-abdominal fluid and potentially a site where to drain this fluid, and to identify the presence of hydronephrosis in patients with acute kidney injury. We are supposed to identify other organs, but not to report on these other organs. There are challenges to our ultrasound imaging of the abdomen, which is mainly the presence of gas that constitute a physical barrier for the ultrasound beam, but also on the non-ideal condition in which an acute patient presents to our care. And last but not least in terms of importance is to, once we have done our study and we have picked up anomalies, request the opinion of an expert just to confirm our findings.